Assalamualaikum and good morning. Today I will present about control of heart and circulation. My supervisor is Dr. Praveena. So for the outlines, we will discuss about the autonomic innervation of the heart and the control of the blood pressure. So there are some past year's questions regarding this topic. SAQ in 2001 and 2002 give a brief account for the compensatory response. Okay, continue. The autonomic innervation of the heart. So autonomic nervous system and circulating hormone serve as important mechanism for regulating cardiac and vascular function. Basically, it is controlled by sensor that monitor the blood pressure. We have baroreceptor, volume receptor, chemoreceptor, and plasma osmolarity osmoreceptor. Autonomic regulation of CDF function is controlled by the CNS, which contain of medulla oblongata, containing parasympathetic and sympathetic nervous system cell body, hypothalamus, which is integrative role in modulating medullary neuronal activity, and cortical region. The higher center, which alter CBS function during times of emotional stress. So the central nervous system receives sensory afferent input from the peripheral sensor and from sensor within the brain. So afferent input from peripheral baroreceptor and chemoreceptor, as well as respiratory stress receptor, enter the medulla at the nucleus tractus solitarius, NTS. So heart is innervated by both sympathetic and parasympathetic nervous system, which control the chronotropy, heart rate, inotropy, contractility, dromotropy, conduction, and coronary circulation. So basically, in the resting heart, parasympathetic nervous system predominate in the heart. So in this diagram, we can see that there is a receptor afferent from the baroreceptor, send the impulse to the medulla and enter medulla at the nucleus tractus solitarius, and then it will project inhibitory interneuron to the sympathetic neuron in the rostral ventrolateral medulla, and excitatory neuron to the vagus neuron in the dorsal vagal nucleus and nucleus ambiguous. The medulla also receive input from the higher center and also the hypothalamus. So the sympathetic and parasympathetic will send the input back to the blood vessel and the heart. So for the parasympathetic stimulation, parasympathetic vagal fibers innervating the heart originate from cell body located within the medulla of the brainstem. These cell bodies are found in collection of neuron called the dorsal vagal nucleus and nucleus ambiguous. So increased activity of this nuclei reduce SA node firing, which gives negative inotropy and slow AV node conduction, negative chromotropy. So it is important to note that under normal resting condition, these neurons are tonically active, thereby producing what is termed vagal tone on the heart, resulting in resting heart rate significantly below the intrinsic firing of the SA nodal pacemaker.
Right, sorry. So the reason I'm late is because I was looking for a past year question that has this topic. So this topic, this topic, when you look at the slides, is just the same thing that is in your textbook, isn't it? Sympathetic effect of sympathetic, parasympathetic effect of parasympathetic. But in exam, it's not so straightforward. So it's completely different. Whatever she's presented, she's very good, very detailed, but it's all in your textbook. So what I'm going to do to be disruptive to her session is that I've brought Viva questions that had come out in the recent exams recent couple of exams. So, is it possible to get any volunteers to sit up here to just try to answer the questions? All right. And then I will tell you what was important to the examiner's point of view and what wasn't important. All right. Can I get any volunteers? I'm not going to pick names. Anyone, please can have a hot seat in front here. I've got 3 quick questions to go through, after which then she needs to complete her slides, and we've got 45 minutes. So anyone quickly sit in front here, and I'll just start the Viva, and so that you know what is the topic related to. Otherwise, it's boring topic, right? Keluar mana, masuk mana, keluar mana, positive mana, negative mana. Come quickly. Can I have someone to sit in the hot seat in front? I'm not going to murder you, but if you are so scared to see me now, you will be very scared during the actual exam. All right, but you, congratulations on being very brave. So I'm just going to go slowly through these questions. All right, you just try your best to, whatever you understand about the topic, and just present. Do you need the mic? Nanti I pass kat you lah. Okay, a trauma patient acutely loses about 1 liter of blood. And that was in her first slide, isn't it? About the past year question. How does the baroreceptor reflex respond to hemorrhage?
Blood loss about blood loss about 1 liter is estimate about 50% of blood loss possible. The hemorrhagic is stage 2 lah. So the compensation of the body is to maintain the MAP and increase the heart rate lah. So baroreceptor activation we start with loss of volume will decrease because of the baroreceptor is the mechanoreceptor. So decrease of the stretch of the baroreceptor will reduce the firing rate to the trigger is the volume loss and stretch mechanoreceptor. Reduce stretch pressure, arterial pressure, arterial blood pressure, stretch, arterial pressure and volume, no arterial receptor. Pulse pressure.
Answer we get is decrease in volume.
Yeah, stress. Stress.
I increase volume, the baroreceptor gets activated. But what are we looking for? We're looking for
Arterial pressure and pulse pressure reduce.
So first, in the error, the examiner asks a question about reflex. What are components of the reflex?
Reflex.
Reflex. When I say I want to know something, reflex.
Sensor, afferent, controller, effector. Afferent, effector.
Sensors deal and what is the effect? Right. So now you're talking about trigger. Monitor blood loss, you're looking for decrease in
Arterial pressure and pulse pressure.
the sensor. So what does it sense actually?
Volume loss of the trigger by volume loss, and then reduce the pressure of the pulse pressure and arterial pressure.
Sense, you're sensing pressure or you're sensing what? What is sense?
Stress.
Stress. Isn't very particular. Mechanoreceptor is a reduction in
Stress.
Where?
At the atrium.
Atrium?
Aortic arch and carotid sinus. Sorry.
Aortic
Arch,
and
carotid sinus.
excellent. So reduction in stretch where? Aortic arch.
And
carotid
carotid sinus.
Effect of this will be what happens, what then the baroreceptor does when there's reduction in stretch.
Reduce firing rate to NTS.
Very good. So reduce in firing rate. Okay. So what is the afferent there?
Vasomotor
Reflex, right?
center.
So go back to your side. Yeah, the afferent. What is the nerve that is involved? So from the carotid sinus, what nerve?
Carotid sinus, glossopharyngeal nerve.
Excellent. You know it when you're not saying it. So 1 liter blood loss, the trigger is decrease in,
Stress,
no, the trigger,
Pressure.
decrease in what pressure?
pulse pressure, atrial pressure,
Excellent. Sensed by,
sent by stretch mechanoreceptor,
located in,
aortic arch and carotid sinus.
excellent. So the carotid sinus will send firing rate through,
From glossopharyngeal and aortic arch, vagus nerve to the
Excellent. Goes where?
NTS, nucleus tractus
don't say
solitarius.
the NTS. Okay, you want to say NTS, don't use the word NTS to begin with.
So
What is NTS stand for? Examiner will ask you.
nucleus tractus solitarius,
Location,
medulla,
excellent. So this is known as, dalam figure, you have trigger, you have sensor,
afferent,
afferent is the nerve. This is what?
controller,
Integrating center, controller. Location is
medulla.
medulla. Now, what is the effect of it? Effect is the effect of this controller, the output of the controller will go to how many organs?
Heart, vasculature, organ,
What organ? Heart, vasculature, one more organ.
kidney.
Excellent. So what happened to the heart?
Heart, we increase the sympathetic for
That's sympathetic. That's semua tu.
chronotropy, thermotropy increase, lusitropy
So
reduce,
heart rate increase.
conduction system.
Vessel, what happened?
Vessel vasoconstrict, and then vasoconstrict the vessel, increase the effective blood
So vessel,
volume.
when you talk about vessel, vessel constriction, which circulation is that?
Arterial.
Arteries.
Venal,
So what happened to venous?
venoconstriction,
So vessel, what words am I looking for?
vasoconstriction,
And
venoconstriction,
you lose the word, you lose your mark. Understood? Number 3, what was the other organ?
renal,
Apa jadi kat situ?
reduce renal perfusion,
Okay, stop. Sampai situ. So what is the net effect of this?
endocrine involvement,
Tak, net effect of the entire baroreceptor.
increase
The aim of it lah,
increase the blood volume, restore the MAP.
So is the net effect just to increase the blood volume? You can't increase blood volume, right? You are trying to increase the
Increase the effective
blood pressure, right?
pressure.
Receptor increases blood pressure. Dia bukan osmoreceptor to increase volume. So again, your words.
Increase blood
The
pressure,
effect is to restore
restore MAP,
blood pressure, MAP. Why?
to maintain a perfusion of organ,
Where?
heart and brain, main
Vital organ.
vital organ.
Ini baru satu soalan ni. Ini macam lead-in question.
And detail.
Next person, get another person to sit here. Come quickly. Kalau tak sempat soalan, korang yang wasted time. Next person, cepat. After that, already figure out who's the next person for hot seat. Quickly. Explain the role of peripheral chemoreceptors in hemorrhagic state. So you see, this question won't be stuck in cardiovascular. It will always move to the acid, base, and all that kind of stuff. So explain the role of peripheral chemoreceptor in hemorrhagic state.
Peripheral chemoreceptor,
So now 1 liter blood loss. So
1 liter blood loss, it is class 2 blood loss lah. It is about 15 to 30%.
All in all, I know. She also repeated the same answer. We already move on to second question.
So 1 liter blood loss, it will cause peripheral chemoreceptor will sense reduce stretch to get right atrium,
Peripheral chemoreceptor will sense reduced stretch. Agree or true false?
reduce blood
False.
volume.
What does peripheral chemoreceptor detect?
or chemical.
Chemical component, which is in 1 liter blood loss, what is detected? When you have patient bleeding in OT, you do a ABG, what do you notice?
PaO2 will reduce.
Okay, so what is your trigger now for peripheral chemoreceptor in blood loss? What triggers the peripheral chemoreceptor?
Is it acidosis, hypoxia?
Hypoxia, and lacu je jawapan dia bila bukan hot seat. Bila duduk hot seat senyap belaka. Ni pula bila duduk situ bising pula jawapan dia. Ayo. So what is the trigger for peripheral chemoreceptor?
Chemical lah actually. Hypoxia, hypercapnia, and acidosis.
Excellent. So that's the word I'm looking for peripheral chemoreceptor. So then what happens? Again, sensor. Itu trigger, sensor.
It will sense to
What
the
sensors? Peripheral chemoreceptor. So where located? Dia template sama je pun.
uh,
Somewhere as baroreceptor.
dekat Arctic
Locations.
body,
Carotid body and
Arctic,
aortic.
Arctic,
Aortic what?
Arctic body,
Carotid body, aortic body. So when you use the word body, then it's
bodies.
right. So what does it actually detect? Changes
Actually, chemical.
What changes? You said already earlier. Changes in what does peripheral chemoreceptor actually detect?
Hypoxia,
So there are
hypercapnia.
three triggers, right? You told me hypoxia, hypercapnia, and acidosis. Among these three, for a peripheral chemoreceptor, it especially sensitive to which one?
Hypoxia.
Hypoxia. You must state it. You must state it. All right. So now you tell me what is the efferent now? From what? From which you have two bodies, right? What are the respective efferent nerve? Carotid body, what nerve?
Vagus nerve.
Vagus nerve, I sayang.
Glo-
If this aortic arch has vagus nerve, this aortic body will have what nerve?
Glossopharyngeal.
Ayo,
Salah.
vagus nerve lah juga. Buat apa vagus nerve tu nak bergerak-gerak? Kan? Aortic body, aortic arch around the same place, right? So aortic body, aortic arch, he said aortic body baroreceptor has what nerve? Vagus nerve, right? So why you answer tukar pula glossopharyngeal? Aortic nerve lah, vagus nerve lah juga. Carotid body, what nerve?
Glossopharyngeal nerve.
Similar answer. All right, that's the efferent. Then you go to the integrating center controller. What's the controller? These impulses are sent to.
Medulla also.
Why you say medulla? What is there? What's in the medulla?
Sama juga nucleus tractus solitarius.
Louder, tak dengar dah. Lagi lama
Dekat
lagi
NTS.
sedih. No soalan. Saya pun kena macam tu masa exam. Oh ya adik, cepat sikit. Cepat. What is the name of the control, the center?
Sama juga NTS, nucleus tractus.
NTS, louder. What is there? What is the controller?
Nucleus tractus solitarius.
Lagi loud dari you.
Nucleus tractus solitarius.
Exactly right. Located.
In medulla.
Excellent. End organ effect. What are the organs? He told 3 organs, right? You tell me how many organs?
3 also.
Ayo, buat macam ni masa exam pun orang tak faham.
Oh, 4.
So what is the 4 organ? What is the additional organ?
Lungs lah.
Bagus jawapan. Duduk luar bilik Maiwa jawab. Baru boleh pass. Dalam saksi tak boleh jawab. Ini macam you see the glaucoma, the doctor glaucoma factor in the NS selalu ada drip. Bila ada drip boleh jawab, tak ada drip tak boleh jawab. Right. Apa dia? Effect.
It will increase respiration.
What organ now you say?
Lungs.
Respiratory system lah. Mana boleh
Respiratory
lah.
system.
So what is the effect?
It will increase, especially will be more tachypnea.
So
Increase
what's the
respiration
word to
rate.
use? When you're in OT and you want to increase the respiratory, what do you actually increase what?
Hyperventilation.
So you're increasing ventilation, right?
Increase ventilation.
So the right word to use is increase ventilation. Don't say patient become tachypneic. Yeah, lah tachypneic. But the right word to use is increase
In
ventilation. Okay, why you increase ventilation? What the body trying to do? It's trying to correct what?
The acidosis.
As well, but more important than acidosis.
To reduce the partial
More
pressure.
important than the acidosis, what is the body trying to correct? The trigger, the most sensitive
Or
trigger was.
hypoxia.
So what is the body trying to correct?
Will increase the oxygenation.
Right? Is it increase? No, it's trying to correct the hypoxia.
Oh.
When you say increase oxygenation, maksud lain, you know. The increased hypoxia is trying to correct the hypoxia, as well as the acidosis. Peripheral chemoreceptor, the keyword is what here. The sensitivity is to
Hypoxia.
hypoxia is very important. The body doesn't want it to be hypoxic. So everything is garnered towards correcting hypoxia. Okay, so then there are 3 other organs which he mentioned, right? What is the other organ?
Was heart.
Heart. Okay, tell me what happened to the heart?
It will increase.
Louder. Tak
Increase.
dengar.
Increase anatropy. Increase heart rate.
Okay,
increase
next organ.
contractility.
Next organ.
Next organ is vasoconstriction and renal constriction.
Next organ.
Next organ renal.
Apa dia? Krik-krik.
No.
Cobalah. Apa? Rina buat apa? What was his answer? Tak dengar jawapan Badihah. Rina buat apa Badihah? So, the net
Will
effect
activate
decrease in?
or decrease in renal perfusion.
Correct. That's why you got reduce in output, right? Net effect is?
To restore the mean arterial pressure.
Okay. If you realize the both answers are the same, similar. So if you're similar, examiner will push you through. Push, 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 push. But that one also stuck, this one 100% stuck. You understand? So examiner will push you through by only certain points that we want to hear, location of peripheral chemoreceptor, triggers to it, because the rest of the answer kind of lebih kurang. The CBS, the vascular, the heart rate, all same answer. But the addition is respiratory system. So I'm waiting for the answer. Increase in ventilation.
Ventilation.
The next person. Cepat. Ni soalan satu pun dah habis. Pukul berapa korang? If you all are late, you won't go through your question, then I just bypass. Okay, okay. Describe the role of renin, angiotensin, aldosterone system in restoring blood volume post hemorrhage.
When the blood loss, there will be reduced perfusion to the kidney. So the kidney will sense the reduced hypoperfusion at the juxtamedullary glomerulus. So it will
Cancer dia dekat dasar glomerulus juga. For kidney.
macula densa.
What does macula densa sense?
Sense
Does it send in the distal tubule? Within the distal tubule, what does it send? Itu jawapan dia. What does it sense? This picture must come out, no? When during exam, there's one like projector out in front of the examiner head, no?
Okay. Okay, so decrease in renal perfusion will be detected by the juxtaglomerular apparatus. So it will cause release of the renin.
Before release of renin is correct answer. Tapi sebelum tu, dekat distal tubule, what does it sense? When there's a reduce in renal perfusion pressure, what happened to the content of the fluid within the tubules? What happened to the sodium?
More concentrated.
More concentrate, and there's decrease in renal perfusion, right? There's decrease renal perfusion, the hemorrhage. What happens to the content of that fluid within the distal tubules? Within the distal tubule. What happens to the sodium concentration? Reduce, and that is what detected by macula densa.
Oh, okay.
Okay, all right. Then only you say release of renin by the JG cells.
GG cell.
So what does renin do?
So renin will convert the angiotensinogen produced by the liver into angiotensin 1, and then angiotensin 1 will circulate into the lung and will be converted by the ACE enzyme.
What is ACE what does ACE stand for? Like that lah, the answer.
Angiotensin converting enzyme.
And what does it do?
Then it will
What
convert
does ACE do?
it will convert angiotensin 1 to angiotensin 2.
Good.
And then angiotensin 2 will have a few effects, which is the increase in sympathetic activity.
I don't say all that lah. The whole topic about control of circulation. Jangan waste time. You have 5 minutes, no. The more you optimize your time, the more marks you get. So what is the effect of angiotensin 2? By organ lah.
So by organ, first thing, it will in the adrenal gland, it will increase production of the aldosterone, and then.
So what does that do? So you cannot just say adrenal gland. Where is aldosterone produced?
Oh.
That is good, but to get the answer, impossible in exam. So what is an easier answer than glomerulosa? Adrenal cortex. Don't say adrenal gland.
Okay.
You're a good candidate. You must tell the detail. So aldosterone, you must practice telling the details. If you don't practice, you will answer like that. So the aldosterone comes out from the adrenal Of course,
cortex.
you can give me the zona glomerulosa, I'm very happy lah. But you need to get the answer of at least adrenal cortex. What does aldosterone do?
Aldosterone will increase the absorption of the sodium,
And
and then water will follow the sodium. So that
from where?
from the distal convoluting tubule,
And what does that do? What's the effect of that?
effect will increase the blood volume.
Okay, excellent. Next point. What is
So
the effect of angiotensin 2? Baru satu.
okay,
ada empat.
another thing, it will affect to the vessel. So it will cause the vasoconstriction.
Okay, what's the effect of that?
So increase SVR will increase in MAP lah. So
Okay, next point.
and then it will also go to the pituitary gland. Pituitary gland will
Again, don't be
okay.
general. Which
Posterior lobe of the pituitary gland.
does it stimulate?
It will stimulate the ADH secretion. So ADH secretion will lead to the water reabsorption at the collecting duct.
I'll just stop you there. Excellent students will talk about aquaporin because they are like a
Okay.
train, you know. Have you seen bullet train before? Macam you tell one word, verboria, you know, is just talking. And when you talk very fast, you can come up with extra points.
Okay.
That's excellent candidates. Okay, because for us, the barometer is 1 to 10. So our barometer is moving all the time. Initially, you start strong, and barometer goes there. Then you go down, then you go up, then you go down. You're trying to figure out where you stand. Huh? Okay, then one more. Satu lagi. The hypothalamus, what happened?
Hypothalamus.
Huh? What receptor? Osmoreceptor. Yeah, but essentially what we're trying to stimulate? The center. And this will increase your
Okay.
intake. That's it. Next person, come sit down. Cepat-cepat lah. If not, I cannot finish. You lose out. Nanti tengoklah kalau mana ada jawapan, you lose. Sorry lah. Sebab kalau tak, nanti you don't understand the importance. Cepat, please. Don't have an empty chair. Korang empty chair, I belah, pergi buat kerja I. Kalau korang tak nak duduk, I pun tak nak duduk. I give you 5 seconds to sit up the chair. 1. This is like when I deal with my 5-year-old, 6-year-old. 1, 2, 3. Please, figure out the next person. Don't bloody waste my time. Okay. What is the effect of central ischemic response in severe hemorrhage?
Central ischemic response in severe hemorrhage. In severe hemorrhage, there is the reduce in the blood volume in the body, so it will reduce the cardiac output to the.
So when is this central ischemic response gets triggered? Around when? You know, when obviously it's severe hemorrhagic shock, right? Severe. Suddenly you get this central ischemic response. So at which point you think that it starts to get triggered? How bad is the hemorrhage that you get this kind of central ischemic response? Must be very bad, right?
Yes.
So MAP berapa selalu?
MAP less than 60,
Less than
60.
50, approximately 50. So something approximately less than 50, it triggers this central ischemic
Ischemic
response. Don't other candidates don't know what is central ischemic response masa exam. They're blinking at us, you don't know what to say. Okay, so around less than 50. Okay. What is this central ischemic response trying to do? What is it trying to protect?
To maintain the perfusion to the brain.
Exactly right. So it's trying to preserve your cerebral
Perfusion.
So what happened? How?
There is a redistribution of the blood from the other.
So before redistribution, right, obviously something senses this. Obviously something senses this severe drop in MAP, right? So normally what senses it? Something is getting ischemic. So what is getting ischemic? Your
brain cell.
brain is getting ischemic. So which part of the brain senses this? Tadi kan Asyik cakap benda yang sama.
Medulla.
Okay, so medulla has sensing this severe. What is it actually sensing? Reduce what? Reduce perfusion,
Perfusion
but
to
what perfusion? Cerebral?
cerebral perfusion.
A game taboo. Where I'm not supposed to say the word, but then I'm like acting on the word. Pernah main tak taboo? Nanti korang main. Dia macam ada perkataan tu tapi dia tak boleh bagi tahu perkataan tu. You kena describe in other ways. So that's what I'm doing with you. So reduce in cerebral blood flow. Okay. So dia sense apa sebenarnya? Ingat tak tadi peripheral chemoreceptor, baroreceptor, they are sensing a few things. So what is it that is sensed that is so powerful? No?
CO2.
So CO2.
Reduce the number of
CO2 ke? Up CO2.
increase
Up.
the number of CO2.
Hypercapnia. The other thing that is sensed, that's very sensitive to sense. Ya ke acid? Kan tadi ada trigger, few things, right?
Hypoxia.
Hypoxia. So the hypoxia and the
And
hypercapnia is very powerful. So what happened to the sympathetic nervous system?
Sympathetic will be triggered,
Memang dah activated, right?
activated.
But when this happens, what happened to it? It needs to go into like turbo drive, right? Isn't it? Sebab dia cerebral ischemia, isn't it? So what will happen to the sympathetic outflow? Will increase further or not? I mean, normally it's already increased. Your hypoxia, you blood loss 1 liter. But when this happens, it will go even
Increase further.
So then what happens, the effect of that?
Then
Again, got few organ, right? So what happens?
okay, to increase the heart rate,
Exactly right. Increase the heart rate, some more.
increase the contraction,
Okay, some more. One more.
increase the
Apa lagi? Vessel.
vasoconstriction.
Veno ke? Bila
Vasoconstriction.
the cerebral ischemia,
Sorry,
dah tak ada room for veno. So
Vasoconstriction.
it's very intense. So essentially, you're trying to increase what?
Increase the pressure.
Before you increase the pressure, you're increasing before you reach the heart is what?
SVR.
SVR, total peripheral resistance. And this response, does it last for a long, long, long time? Sekejap je.
Sekejap.
Sekejap
Break.
je. Sekejap sahaja. And if this doesn't get corrected, what happens to the patient?
Ischemia.
Cerebral ischemia or severe intractable? Intractable what? Hypo what? Hypoglycemia. Hypertension lah. Hypovolemic shock lah.
Hypovolemic shock.
Ni tak sampai lagi soalan ni. Baru first soalan first pass. We got 2 more questions. You guys are not finish. Next person. Cepat. Nanti I buat macam budak sekolah anak I. I kira 5 je. Nanti I belah. 1, 2, 3, 4. I belah. I honestly tell you, I got other things to do. Sit down. The mic is there. So the online people can hear. Now, explain how reabsorption of interstitial fluid occurs in hemorrhage. Explain how reabsorption of interstitial fluid occurs in hemorrhage. So what happens in hemorrhage again?
Hemorrhage will be loss of circulating volume.
Correct. So then what happens when there's loss of circulating volume? What happens in the capillaries?
So in the capillaries, there'll be atriolar and capillary constriction.
Explain how reabsorption of interstitial fluid occurs in hemorrhage. So straight away, Starling forces. You're moving. We move from the heart to the kidney, then we jump to the brain. Now we're going to Starling forces, capillaries. So now you're sitting in the capillaries. Explain how reabsorption of interstitial fluid occurs in hemorrhage.
So due to the loss of the circulating volume, the Starling forces of the capillaries will be affected, which involves 2 hydrostatic forces and hydrostatic
pressure.
pressure.
Hydrostatic forces. What is it? What gets affected? To the point. When there's decrease in blood circulating volume, what hydrostatic pressure gets affected? There are 2 hydrostatic pressures in the Starling forces, which are capillary and
interstitial.
Interstitial. Which one gets affected?
Capillary.
Capillary. What happened? Up or down?
Down.
Down. Done. That's the first answer. Second. So when there's decrease in capillary hydrostatic pressure, what happens to the fluid movement?
You reabsorb from
where to where?
interstitium into the capillary.
That's it. That's all the answer is. Short. That's about it. Now describe the effect of metabolic acidosis in hemorrhagic shock.
Metabolic acidosis, so there'll be increase in
What affects what
Hydration.
system, organ system, first of all? You mentioned
Cardiac,
again,
renal.
cardiac, good. Tell me, what is the effect of metabolic acidosis on the heart?
So increase in decrease in pH causing the acidosis will depress the cardiac.
Cardiac what? Will depress the cardiac what? Contractility. Therefore, reduce the,
Cardiac output.
exactly. So that's one point. Vascular system, what is the effect? Metabolic acidosis, what happened? When you're running a NORAD, what happened?
Vasoconstriction.
Does it work when there's
No.
metabolic acidosis? So there's reduce in what towards catecholamines?
Response.
Yes,
Sensitivity.
sensitivity, responsiveness, isn't it? So then you don't get that vasoconstriction that you want and you get hypertension, right? Another effect, what about on the cell when you have acidosis?
Lysis.
Say again,
Lysis. Cell lysis leading to hyperkalemia.
you won't have lysis. If what happened? What happened to the transport mechanism across the cells?
Decrease.
Does it require ATP?
Yes.
Yep. So there's impact in. Wait. This flow must answer whatever outside. Tell me the answer. What?
Aerobic will become anaerobic.
So basically a disruption of cellular what?
Metabolism.
Is it cellular metabolism? What happens in the cell? What's located within the cell wall? Hello, what's on the cell wall? Siapa present topic cell wall? Tak ada.
Transport mechanism.
Transport mechanism, ion gradient. So you get cell lysis because of that. So when you say cell lysis, you don't get the answer actually. There's a lot of processes in between. So again, what is the systemic effect, the overall effect with metabolic acidosis? You in ICU, patient got metabolic acidosis, hypovolemic shock. What happened to the patient? Patient has
Multi-organ failure.
that's it, end of question. Okay, so this is how hypovolemic shock in this topic is asked. Okay, you realize, jump from heart to effect of heart, baroreceptor, then to the lung, then to the brain, then to the cells. Okay, but whether you reach the cells or not, don't know lah. Whether yours was, I think yours started off type 2 shock, type 3 shock, type 4 shock. Ni pun type 4. Tak boleh jawab. Next person, come on, don't waste my time. Come on, quickly. Otherwise, you don't know how we ask question. Who's next? Do I have to do the regular stuff? 1, 2, 3, 4. Please, thank you very much. Who's the next after her? Don't waste my time. Who's next after her? Put up your hand. And don't look up and down. These girls, come on. We consistently have boys sitting here, except for one girl. No volunteer after this. I'm leaving this class after this then. A 40-year-old man not known to have any medical disease for elective surgery. His resting heart rate is 40 beats per minute, regular. His blood pressure is 90/50, and he denied being on any medication. Okay, what is your concern? I repeat the question sebab panjang Survival like that you have to dengar sepenuh hati, sejiwa. Okay, a 40-year-old man not known to have medical disease, planned for elective op. His resting heart rate is 40 beats per minute, regular. Blood pressure is 90/50 millimeter mercury. He denied being on any medication. What is your concern?
My concern is about the more to the heart rate,
Okay, what about the heart rate?
because the resting heart rate is below than usual normal.
So what is
Which
that term in medical terms? When the resting heart rate is below the usual value? Is there a term for it?
Vagal tone,
What is the term when the resting heart rate is below the usual number?
bradycardia.
Excellent. So what is your concern with bradycardia?
My concern is with bradycardia, it will reduce the cardiac output because from the
Will reduce the
equation
cardiac output and therefore reduce the
reduce the venous return,
and
reduce the
therefore,
stroke volume.
Well, let's not go to that. So reduce the cardiac output and essentially reduce the
blood pressure,
blood pressure and essentially
reduce perfusion to the vital organs.
excellent. So what is the equation relating cardiac output to heart rate?
Cardiac output is equal to the stroke volume times the heart rate.
What is heart rate? While you're standing, you go to the board. What is heart rate? Sebab lepas ni you kena lukis. Pergi, duduk situ. What is heart rate? Jawab. Sementara berjalan tu boleh kan? Boleh jawab. What is heart rate?
Heart rate is the intrinsic ability of the heart to
Of what in the heart? Intrinsic ability of who in the heart?
and intrinsic ability of the heart to contract the blood per unit.
The heart doesn't trigger that rate, isn't it? What triggers the rate?
Automaticity.
No, my dear. What triggers the rate in the heart? Your heart rate is determined by what note lah?
Oh, I say no.
Oh, I say note. My God, this is like mind taboo. Fail already. I'm fail. I cannot say what note. I cannot use the word note with you. So the heart is an intrinsic function of the heart rate is an intrinsic function of what
Function of
note?
the SA node.
SA node, and this is affected by SA
Uh,
node is affected by
autonomic systems, parasympathetic and
autonomic.
sympathetic.
Lagi
Uh,
3 autonomic.
Autonomic.
Mana dalam your punya ni? Autonomic. Apa lagi? Cepat. Autonomic. After that, autonomic. The SA node is affected by. Very good. It's humoral. Satu lagi. And local factors lah. Normal heart rate.
normal heart rate 60, 80.
Tachycardia is defined as
Heart rate.
above the normal.
Heart rate.
Tachycardia is defined as based on ACLS guideline. If you're studying for exam and you're going to be anesthetist, not Floris. Heart rate more than normal is defined as tachycardia definition. Heart rate more than. Therefore, what is normal heart rate? 60. Oh, imagine you kena rapid fire with me masa Viva. Oh, mengeluh you. Nanti go outside cry. Cannot. Must try. Okay. Now you take the marker pen. Draw a graph. The relationship between heart rate and stroke volume. Heart rate, stroke volume. It's already 8:45, right? Please, if we can finish this question, that would be great. So what are your axes? Label your axes. Are you sure? Are you sure, my dear? Okay, thank you. That is heart rate. Stroke volume is where? So how you draw a relationship between heart rate and stroke volume? So the higher the heart rate, the higher the stroke volume. Are you sure? Yeah. Are you sure? Jangan tolong. Are you sure? You all heart shape all, you all sit down. You sit down there. Higher the heart rate, higher the stroke volume. Then why we got ACLS guideline for SVT? You should be happy, what? Heart rate 200. Patient in ICU, heart rate 200. Happy or not happy? Not happy. But the graph look very happy only. Higher, heart rate 250. Heart rate 300. Happy or not happy? What happened when the heart rate 300? So it doesn't look in your graph. It doesn't explain what you are saying and what you have drawn. Heart rate 500. Heart rate 600. Apa you punya stroke volume macam tu? Tukarlah jawapan. Padam. So, heart rate going up. Heart rate 1000. What is your stroke volume? Heart rate 2000. Heart rate 3000. What's your stroke volume? Now heart rate is 80. What's your stroke volume? Put a plot, heart rate 80, write down there heart rate 80. How much your stroke volume? Heart rate 80. How many, around, a plot, put an X. Put an X in the middle of your graph. Where your heart rate, where will you X it? You know how to plot a graph? Put an X above the 80, where you want it to be. Okay, put an X there. Put an X. Draw an X there. Excellent. Now, heart rate 1000. Write word 1000 on the right hand side. Your heart rate is 1000. Where's your cardiac output? Draw an X. Now draw a line. This is how in exam I struggle. You see my struggle? That's why I must have a lot of coffee when you become Viva examiner. I must pray a lot, meditate a lot. Because you want her to pass. You understand? That's why I'm pushing you. Because I got 5 minutes to accomplish the job. Therefore, what's the relationship of heart rate versus stroke volume? So, at the heart rate optimum, the stroke volume will be optimum. But when increasing in the heart rate, it will reduce in stroke volume because it is less than correct. Of course, this is not a perfect figure. You can actually look it up. But in exam situation, when the student cannot figure it out, we just want to know whether you understand the topic. That's why I told you target 1000, so that you figure out that there is a reduce in your stroke volume. You understand? So when an examiner is leading you in an exam, don't get stressed. Yeah, I'm shouting at you, but actually I just trying to get you through. You understand? If you just listen to the question, listen to what examiner wants. You know how some students come out exam and say, I don't know what that examiner trying to tell me. Because we're leading you towards that picture. In an exam, you don't draw the line, you're out of the game, totally out. Okay? Because you haven't reached your pass level yet. Okay? Now, things get more interesting. Explain the relationship now between heart rate and cardiac output. Draw another graph. Heart rate, cardiac output. So you see the obsession with drawing. NSFPs love drawing, you know. Stroke volume, heart rate and cardiac output. You need to have your units, heart rate. Cardiac output is mila. Okay. Draw. Any numbers on the heart rate column that you want to mark because you seem to have different lines for different things? And your line, is it complete? Is that the end of your line? Your graph? All right, and any markers of so any heart rate values there when your line goes down? Write the number then. Okay, so let's talk about the first part, that first line going up. So your shape and all is excellent. The first part, the first line going up, what do you want to tell me about it? Let's just label it as A. Okay, tell me about bahagian A. What do you interpret from it?
Dependent.
So what about cardiac output at that point? When your heart rate increases, your cardiac output, so it's dependent on your, so cardiac output is heart rate dependent at bahagian A. What about bahagian B? Maximum So what I'm going to do is, I'm going to ask you to write the formula at the top. Cardiac output equals to, just write above ke below, right. Cardiac output sama dengan CO equals to heart rate times, tak payah tulis penuh lah my dear. HR times SV lah, cepat lah. You got no time. Come, bahagian B. So the bahagian A, cardiac output is dependent on heart rate. Okay, bahagian B. Say again, I can't hear you. Therefore, dependent on what? If it's independent, you got a formula there. So cardiac output in bahagian B is depend on, you just said it, depend on Y. Why in bahagian B, cardiac output depend on stroke volume and not depend on heart rate? What happened?
Autonomic.
Does it reduce contractility of the heart? It reduces what? Just pump out the blood, reduce the ability of what time gets affected? Yes, and therefore reduce the stroke volume. That doesn't reduce the stroke volume. Therefore, it's not heart rate dependent. It is then now dependent on the stroke volume because your diastolic time is already affected. Do I make sense or not really? Faham tak? You need to understand this is Dr. Omar's famous graph. Bahagian C. What about? Sorry sayang. Bahagian, sorry. Dekat exam dia label salah ni. Bukan label salah, dia opposite. So my explanation for you, the one that is stroke volume dependent is actually for bahagian C, not bahagian B. Sorry, minta maaf. Because kat sini dia B, dia dalam exam ni, dia letak B hujung tu I baca tu. So actually, yang I cakap, the heart, stroke volume dependent is bahagian C. That's why it goes down. So you don't have time to fill up as well. Your diastolic time is super short and you don't have time to fill up. So that's why it becomes stroke volume dependent. So any increase in volume would be the only thing that changes the cardiac output. But it goes down now. So sorry, sayang. Bahagian B, what do you think about? Why is it a plateau? Why bahagian B is a plateau? Sama je cardiac output. Is it auto-regulated? Is cardiac output auto-regulated to a certain extent by what? By your end diastolic volume, your end diastolic volume. Because between the range of around 50 to about 150 it remains at a plateau. Like we can accept, right? Heart rate of 80, maybe sometimes even 120, the cardiac output maintains. Even if you look at our ACLS guideline, they will ask you, right, hemodynamic stability or tak stable, right? There are patients who are quite stable still because you can maintain the cardiac output. And even when you pace also, you can pace within this range to maintain your cardiac output. Logic, right? So that's why the cardiac output, if I read the answer, cardiac output is constant at 5 liters per minute by primary changes at heart rate, which can be modified by pacing or auto-regulated by preload. So heart rate is, because CO equals the heart rate times SV, right? So during that range, the heart rate can be, you can either time it by pacing or you can change your stroke volume, which is something that is auto-regulated lah. And that's why the cardiac output remains plateau. But beyond the bahagian C, your diastolic time is very short. So that's why it becomes stroke volume dependent. Any questions up to this point? Because I think this will be the end of it. Any questions? You all understand this picture? Because this is pre-pass level. Maksudnya you must understand. Kalau you tak dapat dua-dua graph, you're out of exam. You fail the station. So you all understand? Any question? Silly questions you can ask. It just goes down. correct lah what she draw, but just a bit of down. You can Google it up, the picture. But even exam, you draw that also is enough for me. But for me to get you to draw, that's why I have to ask you to X, because you cannot figure out what I'm trying to tell you. When I ask you relationship, you're not sure. You sort of know, but you somehow drawing that there. You realize your candidate is drawing that right-hand side graph onto the left-hand side graph. Nampak kan? So that shows lack of understanding. So you must really understand. That's why I'm asking you, do you understand what I'm trying to explain? Faham tak? You must understand the reason. Kalau tak, masa exam dah lah you stress. Dah lah exam dia membebel, menjerit-jerit kat tepi tu. Tapi you cannot, you will get very confused. So you must actually understand. Okay? Now have a seat.